Hello, everybody. Welcome to the colloquium today. I'm Diane Duffy. I'm one of the directors in the program here. I'm the director of the graduate nursing programs. And I am here to introduce our speaker tonight. It is with great, great pleasure that I'm going to be introducing Marie Ikeda. And she's going to give you a presentation about impacting practice through research, aligning with political will. And I just want to give you a little background on her. She is a professor at the Department of Nursing Administration, School of Nursing, Tokyo Women's Medical University. She is a registered nurse, and she's also a clinical psychologist. Her background, she has an undergraduate degree from the University of Tokyo. She has been to the Graduate School of Education at Tsukuba University, and she has her PhD in Health Sciences from the Graduate School of Medicine Department of Family Nursing. She has many, many articles that have been published in refereed journals, which tells us that it's properly reviewed and they're high-quality publications. She's written on topics such as career advancements of licensed practical nurses. She's written on risk factors for postpartum depression, including working with her colleagues collaboratively to develop instruments for postpartum depression assessment and postpartum bonding, too. A questionnaire on that. For those of you that have ever developed instruments, that's a lot of work. And I think our graduate students, when they get to their capstones, get a little sense of how much work that is to develop instruments. Huge project. She has written on premenstrual distress among Japanese high school students, maternal mental health promotion programs. She's done things with care of the elderly parents, sleep status, she's done some work on. She's worked with and done publications on patients with diabetes with foot care and some glucose levels. And she has also written on experiences of bereaved individuals, among many, many other things. She's had many presentations around the world, so we're greatly honored to have an international speaker here, as well as a great colleague in the nursing profession. And she has a number of funded projects as well. So it is my great honor to introduce to you Dr. Ikeda.
Thank you. Thank you, Duffy. Well, I just want to thank Duffy. Thank you for the nice introduction. It seems like I've done a lot of work, but I've supervised a lot of graduate students and some other younger faculty. So I was not in the main in some of the projects, but it's fun to do a research. And what's fun more is that the research being implemented into a clinical setting and that it will become routine. I don't want to do research just for research. So today I'd like to talk about how I got the theme of my research, which is postpartum depression, and how I involved the clinical people to actually implement it in a setting. And I have designed these researches aligning with the political will sounds very big, but among what the government is looking for, so it will be implemented easier in a regular setting. So I have prepared some of the slides, which should come soon. Okay, since you have the handout, I'm just going to start. With gratitude to the faculty of School of Nursing, I'm here, and I've met your nursing school dean, Patty, and also Judine has, oh, okay, now it's back. Thank you, Mariala, but it's not on the screen. Okay, so the issue that Japan society is facing is that maybe it's the same situation in the United States, maybe not. We have a very low fertility, total fertility rate in Japan, and it's like 1.34. So only mom who is able to give birth only have 1.4 babies I should say baby, it's not babies. So they have a very limited experience of rearing a child. Okay, thank you very much. So this is what I had. Okay, this is where I'm from. See, Japan is in the middle, right here. And you probably have never seen a world map looks like this. And this is where I'm from. It's from Tokyo, center of Tokyo. And this is some of the pictures from my school. And Valley, you know what I'm talking about. And with the gratitude from the faculty, and I met Patty, Professor Patty Varga, and Judy has made this possible to do this travel. So thank you. Okay, so what I was talking about here is the low fertility rate. I don't have to carry this anymore. So low fertility rate is not a big problem by itself, but it decreases the whole population and the working force, and also less experience of seeing little child around you. And this is graph, I'm sorry this is still in Japanese, but this red line here is Japan. In 1950s, we had more than 3.5 children, babies per woman. But here you can see 1966, we experienced a drop of 1.57. We call it 1.57 shock. And this was the lowest, but now it's even lower. And why this is low is it's a very superstitious thing. It's the year of Hinoe Uma, meaning that a woman who is born in this year is very, Hinoe means fire, and has a very, character that has a fire. So it is not good to marry a woman who is born on this year. And guess what? Who is born in this year? So during my lifetime, I've always experienced less population, less competitive in getting anywhere. So I'm pretty lucky, but this is how it was. You probably don't know. It's a Chinese year counting system consisting of the 10 celestial stems and 12 zodiacal signs with 60-year cycle. So this Hinoema comes every 60 years. It's really rare. Anyway, it's not my topic. It's not the main topic, but this is what they experienced in 1966, and now we're around here. And I've heard, this is France, the blue one, and I heard that the social infrastructure and support is being established in France, so the number of babies is increasing. But this is America, United States, but it's much more than what we are experiencing in Asia, in Japan. So, next slide. So I'm a nurse, as Defi has introduced, and I have a clinical experience of meeting moms with worries that they reveal that they hit their child. Is it discipline or is it abuse? I'm worried. And they don't have a person that they can ask right away. So I've been counseling these mothers, and I've noticed that the risk of intergenerational transmission of maybe attachment, trauma, or parenting could appear in perinatal period. What I will explain more about that. And mothers' interpersonal relationship difficulty was leading to this anxiety. They were so worried about getting feedback in line. What's up? Maybe here we have line, the SNS, you know, and they were so worried about mom friends instead of caring for their child and things like that. So when you have a baby, this leads to how my research began, in attachment style and the depression. And I thought it's a key intervention and something that could go beyond. So this is a picture of my baby. Well, when you have a baby and you hold a baby, they look up to you very dependently, believing that you will be protecting the baby. And she has a smile. And when you have a very good experience growing up with a tender mother who will care for you, you feel like you have a responsibility to do the same and feel warm in your heart and happy. Everybody congratulates you when you have a baby. But there are people who have bad experience with their parents or being abused but put away that feeling somewhere else. But when you have a baby, all these feelings and emotion comes back. That's why I say it could be transmitted, the intergenerational transmission. And so this period is very delicate. So I think most of you might know what postpartum depression is. It's not something rare. It happens to 2 out of 10 women who gives birth to a child. That was by the literature says. And the onset is within 4 weeks after childbirth, or maybe a few months. And it is recently reported that even 2 weeks after the birth, it could be occurred. And it's not it's totally different from maternity blue, that the hormone balance right after the birth. It prolongs for a long time. And the problem is the rate of consulting doctor, if you have this depression, it's only 20% even after the onset. And it's just the lack of knowing what the postpartum depression is. So I think it's very problematic that they don't go to specialists. So what is depression? Not just for mothers. Well, depression is a major health problem for all lifespan. And it is a stressing disorder. Maybe you have experienced some people around you who have depression, and it's really tough. And people who are depressed is too depressed to seek for help. So somebody around you have to kind of notice and help them. And it's a common disorder. Like here it says 10% to 20% lifetime, and more women than men is inclined to develop depression. But it's preventable and also treatable. So we should know about it and let them access to a specialist if you find this out, is what I want to stress here. And if mother have depression, what happens to a mother? They have a strong feeling of depression, so they do not have ability to care for the child when the child needs, very care. And negative feeling toward the baby. Everybody says, congratulations, you have a nice, cute baby. And you're just so depressed you can't think about that. And that could develop to a risk of abuse. Not always, but it could be a risk. And what happens to a father, recently they've been reported that paternal depression is there. Not biological reason, but maybe by looking at his wife being depressed, or a lot of work, childbearing work is a burden to father as well, but they don't get enough support as mother does. So that could be a reason, but it's not solved yet what the reasons are. But it says 10% in the United States by the literature. In Japan, 13.8%, 1 month after childbirth is an onset of paternal depression. And what happens to a child when mother has depressed feeling, I've skipped, is that child gives up a desire for attention because mother is not depressed to take care of the child. The I forgot the word. You learn that you don't get attention, so you give up and the baby stops crying for the attention. Learned helplessness. Yes, that's the word. So once the mother recovered, it will be a problem because mother wants to take care of the child, but child does not, respond or doesn't cry anymore. So it could be a risk too for neglect and all that issues. And also, child has a difficult to adjust emotion and behaviors when mother has depression. So I thought, what type of mothers are liable to fall into depression? And I thought that attachment style, that is ability to make and maintain relationships with other people is actually the definition for attachment style. And understanding mother's attachment style while they are pregnant, so I will know who needs more help. So I thought that would be the key. So attachment style is, there's a theory in attachment, and secure attachment is to maintain close relationship to people who are close to you, parents or carer in a childhood, and that will develop a secure base in your mind and trust in others. You would think that you're worth to be cared because you're cared very much. And if you lack the close bond when you're in the childhood or abusive experience, that will relate to insecure attachment and mistrust. So insecure attachment style relates to clinical disorder across the lifespan. And these two, Dr. Mary Einworth and Dr. John Bowlby, is the two big scholars that has established this theory. You probably know about this. And I just want to point out that it's not in your handout, but since I've been here in Alverno, I've seen so much diversity in students and different areas. What is attachment theory and culture? And I found it's very interesting that there are three basic attachment patterns: avoidant and ambivalent, which is insecure, and secure. And that could be found in every culture in which attachment study has been conducted thus far. And it's very universal. And I will show you a data here. This is infant mother classification pattern. Have you ever heard of strange situation procedure? This is to measure the child's attachment style. After like 2 years old, this observation scale could be used. You put your mother and a child in one room with a stranger, and the mother leaves, and child usually cries because, don't leave me kind of thing. They might speak out, but they cry. And the stranger, who the child has never met before, helps the child to soothe down with toys and all that. And the one mother comes back, and the researcher observes how this child acts with mother coming back. And usually when the child has secure attachment style, they soothe down and feeling that, oh, she's back, I'm safe. When the child is avoidant, which means they're not really cared that well, they don't really mind mother leaving. They don't cry. They just say, oh, she's out again. And when she comes back, they really don't mind. They play with stranger instead. And that's really weird, but I have observed once. Ambivalent style is that mother have not consistent child-wearing style. Like sometimes she has no borderline when the child gets in trouble. So child doesn't know when they will be hit or when they will be okay in doing. So when mother leaves, they cling to their mother, they cry, and they don't soothe, even the stranger try to soothe them down. And once their mother's back, they're not happy, they're not secure, they're just angry that why you leave me. And that kind of behavior is observed. Briefly explaining the strange situation procedure. But by using that scale, in Japan, most people, 70% are secure. Isn't it nice to know that they have secure attachment style? But 20% is ambivalent and 12% avoidant. But in Europe, about the same portion. In the United States, same. Instead, it's this opposite. 20% is avoidant. They're more independent. They figure out that, they want to manage, I think. They want to manage their attachment style. So ambivalent, you have to be you have to cry a lot, you have to be angry a lot. So maybe it's the cultural thing. But mainly, I want to stress here is that almost 70% have secure attachment style, which is good. So attachment is seeking support to attachment figure. When you're a child, it's parents or caregiver. But have you ever heard of internal working model? It establishes in your mind that you are worth being cared if you are cared properly. And that kind of model establishes in your mind. And that's how you interact with caregiver. And eventually when you grow up, you have peer and you find partner. And as long as the lifespan, you will develop a close relationship with others using this internal working model in your mind. And that establishes while you're infant. So much for the theory. This is concept model of postpartum depression. Mother with psychosocial vulnerability, along with mother's attachment style. And when stressful life event, I don't want to call childbirth a stressful life event, but it is hard. It's a happy moment, but it's also stressful. After that, you have to do a lot of work. So if you don't have much help and to have an ability to seek help, you will develop a postpartum depression. That's the concept. Okay, so while I was interested in how to prevent postpartum depression, way before they will develop, Japanese government were having this political will of putting Hello Baby program. This is All Japan, Ministry of Health and Welfare and Labor. The reason why they did that was the birth rate was getting very low, and mother was being very lonely and taking care of the child, especially in city. They don't have like community network, and so public health nurse was visiting every mother who has the first child, and that's called Hello Baby program, and that was introduced in 2007. And I've done the research in 2010 after this has been issued. And also, partial amendment of Child Welfare Act, Article 25, was defined for specified expectant mother. This means the mother, we specify a mother who is in great need of support, like single parent mother, single mothers, or mother with low income, and mother who is who comes to a pre-checkup while pregnancy, and we kind of screen out some of the mothers who will need more help. And we will put more resources into those mothers. That was written in this act. So this was able to take preventive measures against child abuse or healthy child rearment smoothly within the obstetric department. So this was what was going on in the political will. So I'm sorry this isn't Japanese, but we had a national campaign in 2006 for a 5-year campaign, like your healthy people 2020, or once it's finished, it becomes 2030, or that kind of campaign was done in Japan. So this is the mother and the child, and all other like institutions should join the team to get the healthy environment for children. So that was what was going on. And I'm just gonna skip, well, I shouldn't skip it. Well, these are the risk factors for mothers who will develop postpartum depression. And this was known, like previous history of depression, lack of support from partners, and negative life events during the pregnancy. But we as a nurse provider, care provider, have opportunities to meet these mothers. And these are the opportunities we have in Japan. We have perinatal visits once in every 4 weeks until 23rd week. It's the same in the United States, probably. Every 2 weeks we meet after 24th week gestation. So in total, we have like 14 prenatal visits per low medical risk pregnancy. So we have a lot of chance to know the mother who is in need, and I think this will be involvement of nurse during this period could enhance the well-being of mother. So I've designed a study 1, which is the relationship between women's attachment style and postnatal depression. The aim of this investigation is to know the mother's attachment style, and that will relate to the risk of postpartum depression. I wanted to know what kind of mother will be inclined to develop postpartum depression. And I also used a questionnaire too, but I've used a instrument called attachment style interview. I interviewed the moms. It takes about an hour interview, so it's not for everybody, but this was a research, so I interviewed all of them. And it will take about an hour, and we will ask about close support and attitude toward the close to others, getting close to others. And we call this very close others. So we ask about your partner and about one very close other. And if you have 2 very close other, we will ask about 3 people. And we have a specific criteria for very close other. Either you meet at least once a month, and you confide what your worries are. And so they pick 2. Some of them don't have any. But we ask them about their partner, even if they don't have a good relationship, it's a default. So partner, and sometimes they don't have any other people. But we ask about the relationship between these 3 people, or 1 people to 3 people. And also we ask this, the negative scale such as mistrust and barriers to closeness, desire of company, and all these scales. and anger and fear of rejection. And we've profiled these scales, and that will fall into your style. It's very pretty complicated. If I talk about this, I will need more hours, so I'm just gonna skip in details. But this is very interesting because it's an hour interview, and they give you a lot of narratives. So you have a lot of information of this client or mother that you could use as in an intervention. So this is how just to give you, maybe it might not help you, but see, partner relationship, very close other relationship, and very close other two relationship. I ask about these three people, and this will lead to ability to make and maintain relationship. So either the degree of attachment is scaled by asking these questions. There are it's a semi-structured interview, so it has a semi-structured interview questions. And then after phase 1, we ask about mistrust, constraint of closeness, these scales, which is will identify the avoidant part of it or anxious part of it, and we profile, and that will put it into a style: enmeshed, fearful, angry, dismissive, or withdrawn. These are the insecure attachment styles, and people who have very good attachment style, a secure attachment style, will fall into secure attachment style. So this is the interview. I hope I'm not boring you. Okay, so these are the results. I've learned that 20%, I met them in their 32 gestation to do the attachment style interview and questionnaire, and I met them right after they have the baby in a ward, and I met them after 1 month when they have a healthy baby checkup, they coming in. And I have had somebody else to diagnose whether they have fallen into a postpartum depression, and I found 21% have met criteria for postpartum depression, which is similar to the literature tells you. And those with insecure attachment style had higher risk of becoming postpartum depression, 7 times more. And if I add attachment style factor in a screening scale, Duffy explained that I developed postpartum depression inventory scale. Actually, I didn't develop from scratch. It was Beck Cheryl. She's very big in postpartum depression area. She has developed this scale, and I developed the Japanese version with cultural interpretation into it. If I add attachment style into the scale, it will increase the prediction rate. So it is important to know that woman's attachment style to predict whether she might have a tendency of developing postpartum depression. And it is said that withdrawn attachment style, this is avoidant, they usually go away from the problem, so they don't actually develop postpartum depression. But we found with this Japanese woman that they are also at the risk of PPD, postpartum depression. So that was the result. And just give you a brief idea of what kind of attachment style this person has. Well, this is one of the examples, Yoshiko. It's not in your handout, but I asked this question and she narrated this, she gave me this story. She was married for 6 years and dated for 6 years before marriage. I asked those kind of questions. She could confide, meaning she could talk about it, in her husband, but he would not listen to her regarding the child-rearing concern. So she's not getting emotional support in what she's really worried about. He often is not cooperative with house chores, and that makes Yoshiko frustrated. And when they get into fight, they won't speak to each other for a while. These are the answers for the questions that I ask. Her VCO, very close other, was her own mother. The mother has chronic illness, so she cannot confine what she's worrying about too much because she doesn't want to make her mother worry about it. And Yoshiko has arranged her mother and mother-in-law and her sister to take turn and visit her house after the baby is born. So she has all that figured out. But it is very difficult for Yoshiko to trust others. This is the answer that I get asking questions with these attachment attitude questions, and make close relationship with others. She was very fearful of what others think other people will think about her when she's being honest with her worry. So Yoshiko thinks that she can manage most of the matter by herself. What happened after she had a baby was she was identified as markedly insecure, fearful attachment style. And her delivery started unexpectedly when water broke, and the baby was being underweight, and that really worried Yoshiko. And the baby also cried continuously. She wasn't expecting the baby to cry that much. Baby cries no matter what. And they just don't have that much experience seeing other people around, so she was so overwhelmed. And those who came to help her, remember, she has fearful attachment style, so she's not really good with people. But after the baby's born, she has many visitors that also overwhelmed her. And she was really depressed. So she took action. This was good. I gave her a feedback that she has kind of, I don't say fearful, I said you have very cautious characteristics in your relationship with others. There are wording that you use for fearful and withdrawn and enmeshed. Because if you say that, they don't really like that word. So for enmeshed, we say you are very social, but maybe not too much social. Well, she took action to ask her husband for a greater amount of help, which she doesn't usually do. And she felt she got better because the husband, once being asked, he did help. So there's another example, Kaori. She was married for 4 years, and she is very highly skilled career woman, very independent. And she says she can confide in her mothers, but she had nobody else. I mean, her only very close other was her mother only. But she was living very far away. She was in Tokyo, and her mother was in Kyoto. It's just not very close. So, but she says everything is taken care of, and she's fine. And she said it is difficult to trust other people because she thinks other people are not smart enough to help me. And she says she can manage almost everything without help. Well, she has a very insecure, withdrawn attachment style. It's markedly because she only had 1 or 2 people who she can confide with, and very withdrawn style. And very too high reliance on oneself and don't seek help for others. But her delivery was well, but the childcare was hard for her. She didn't imagine this would be this hard. And she lost her confidence. She was a very confident woman, but she lost totally and became depressed. And her mother was nice to advise her that, why don't you ask for her mother-in-law's help? And she did. So in both cases, I gave them their attachment style feedback and with advice, and to help them understand their own style. So after getting the results from my research, I have meet with providers and share this information that knowing attachment style of mothers are pretty important to predict who needs more care. And also we have gathered community health, public health nurses and this is not me, this is one of the mental health doctor, but we did like study group and lecture doing that. And also, this is the program I have developed for mothers. It's called Maternal Mental Health Promotion Program. And just to give information of depressive symptoms in postpartum period. And also, I want them to reflect on their pregnancy experiences, because sometimes they forget how happy they were when they found out they're pregnant. Or maybe they were upset because it was not the right timing. All these things should be kind of reflected to prepare for the real birth. And also, the importance of good communication with one partner. And that was, I think, I involved in this program. And since we have a maternal class, I have developed a manual for the providers, midwives, and also a kind of a worksheet. So I gave lecture of body change through pregnancy, and I want to tell them about depression, because some of them don't know what depression is, and they think it's their fault that they're feeling this way, but it just happens 2 out of 10 women, and they should know about it so they could be helped. So these information I provide, and with these kind of worksheet, little bit of lecture, and the worksheet that they can fill out with their husband. But it's mother's class, so I only talk to mothers. They bring back this kind of sheets back home, and I have a feedback from mom who said, this was really good. My husband paid attention. I always say, I learned this and I learned that, but he's like, oh, okay, that's good. You know, doesn't really care much. But if there's a sheet and there's the information, man likes information and likes to read. So they read about what will happen to a mom when first get pregnant and all that. So I think it was a pretty good program. And the thing is that I developed this program in a research, and I share the value of the importance of this development of the research with midwife and nurse managers, and we did provide that to a woman, and we constantly reflected and modify if there's a need. And more nurses came to join the program. They said, I want to do it. I want to facilitate the program, because it seems like people who are in it thought that they could know mothers better than just meeting them in an outpatient clinic. But involving in this program, they could learn more. So, and they said they gained a deep understanding what the mothers are needing. So I have actually did the questionnaire to the mothers, how they felt better about it, and also met them after they have taken this program. And so I spread the research result in conferences in Japan and also overseas. And the decision was made in the clinic, in the university hospital and also clinic, that they will continue the program. This was only done in a research base, but they said, we're going to be doing this continuously because it really means a lot. And so study meetings were held to disseminate the program. And this is a little, I don't know if you can see it, this is a little booklet that mother receives, and that worksheet was shrinked and put it into that booklet. So I think this was good. And what made it possible was that I didn't create another session. It was I put it on to the current maternal class. Maybe 20 minutes more they stay, and I do this lecture and group work. And there's usually 4 mother classes, so I did it twice. Not the same one, but different ones, so that they could develop peer relationship as well, because they do group work. So it was easy for the clinical setting to implement it as a routine program, I suppose. That's what they told me. So I got a feedback from the field that partners are an important part of the family. And I was only approaching to mothers, maternal class. And also after the child is born, mothers said, whatever I did right, no matter what I did right, the child cries, and child temperament is really what's getting me depressed. So I did another research aiming to examine the influences of mother's attachment style and child temperament after the birth, and mother and child interactions and partner relationship. And I got the result that maternal attachment style has significant relationship with mothers who are childbearing on its own. But if you have put it in a child temperament and marital relationship and partner support in it, it didn't matter. It didn't have significant relation with the depressive state in mother, which I thought was also, it could be helped. And in your handout, I think I have the wrong spelling. It's not, it says Marshall, but it's marital. Marital satisfaction and support from partner had significant effect on current depression, I found. So I also had a privilege to meet these. I interviewed 76 people in my first study, and after 3 years, I called on them. Some of them were not there anymore, but I was able to reach to 20 mothers. And among them, 7 mothers had insecure attachment style in their pregnancy, but 5 had positive change in their attachment style, and 1 remained same, and 1 turned into more insecure state. That was the bad news. But see, the one I introduced, Yoshiko, she had really moderately insecure, fearful, but she became mildly, which is the level got better. And also, Kaori, who had markedly insecure withdrawn, was moderate insecure. She was now able to seek help, and her reliance on oneself, too strong reliance on oneself, was becoming more milder. So I think the life events like giving birth could be developing your attachment style in more secure level. So why don't we use that chance to develop those kind of development and enhance that to mothers? And also, I thought about reaching to partners as well. And support marital relationship may possibly prevent depression or mothers in child-rearing period. So I tried to develop another program with couple, not maternal, but both couple, to develop designed to be offered during pregnancy for couples. And in order to do that, I never talked to fathers before. And well, on my private side I have, but not in the research. And whenever I recruit, it's very hard to recruit men. I don't know if you ever experienced doing research. Men are just hesitant. They don't want to talk about anything. But I found that since I've told you about 14 prenatal visits that we have chance to meet moms, and sometimes they bring their husband, partner. And what I hear from partners is, one of the person says, midwife never look at me. They don't care what I think. And it's true, midwife often in Japan focus on moms, how they're feeling, and tell the husband, you have to support your wife, support. And sometimes man feels need of support. They're feeling anxiety too, I found out. And there are parent class, it's optional. Mother class, you have to take this class for mothers who give for the birth for the first time. It's mandatory. If you don't take this class, well, you're allowed to give birth, but it's really mandatory. Sometimes they don't come in, but usually they do, and it's 2 to 4 sessions. But parent class is optional, and it's very limited. Even if they want to take it, it's like once a month, and it's always fill up fast. But if I could put some of the information in this parent class, I thought I could reach to fathers as well. So I did a little bit of research, and first I did literature review. Is there a program that's being done for couples? And I found something out of that, and I did also a focus group interview. I wanted to do a focus group, but those couple didn't want to do group interview. Can you imagine? I mean, they said, well, individually interview is okay, but I don't want to talk with other couples, strange couples. So I was able to do one group interview, but other than that, I did individually, just couple only. And I did a literature review for 5 years of literature. A postpartum depression, couples, program, education was the keyword I used. And I only found 5 study reporting program for couples after childbirth or during both pregnancy and post-childbirth. And the program was mainly, reduced mental disorder in women. That was the result of all these programs. And though the effect of father's mental health was not reported, it was not measured. And so father was not screened for mental health issues in these programs, although it was targeted to couple. That was my founding. And another thing, the focus group, I interviewed couple with this question: how did you feel when you learn about pregnancy? It's like a reflection. And please tell us about any concern about pregnancy or childbirth or child rearing after the child is born. And have you talked with each other about the role you will be taking after the child is born? And do you feel comfortable about it? And these are questions that is very semi-structured interview. And these were the findings. I have only able to do 5 couples, and so it's very few samples. But wife said I was very uncomfortable and concerned about unstable physical condition. That was about it, from wife only. But husband said they were worried about all the information that wife gets surrounding my wife. And they were worried about wife's depression. And also they were so confused with terminology that the health provider uses. But they didn't have much courage to ask back questions. What does it mean? And so they were like confused. And they were also worried about their own anxiety, but they didn't want their wife to detect that. They wanted to hide it. They wanted to act brave. So that's kind of tough for a husband. And from both sides, I have made this category that postpartum depression, and see these people, as you can see, they were all in 30, the wife 30s, just two were in 20s. But you'll be surprised, the average age of Japanese women who give birth for the first time is over 30 in Japan, 30.7 or something, quite old. I mean, there are some teenage mothers still, but it's getting older. So people are worried about this geriatric pregnancy. You know, you could have a lot of risk when you're older. And also, they were not worried. They were not sure what they were worried about, ambiguous worries. And also, heavy pressure in raising a child. This was a big issue to them, and all other things. And I just want to go in detail about, they were not confident enough to become parents, and they were worried about becoming mother, one of the wives said. And from the husband, they were feeling very heavy responsibility of carrying out my child's life. And this feeling is very heavy, so I need someone to take care of this burden. But they have no resources. There's no like classes for husband only. And if you go to the workplace, it's hard for men to talk about these worries, they said. And they were under pressure. They were under pressure of raising a child. So that, for me, was a new finding to me. I thought they were not confident, but they didn't really think about during the pregnancy what they would be doing after the childbirth. So this was a discussion. I thought that this results show that the couple needs more information or more communication while they're in their pregnancy. And the wife was so surprised to find that their husband was worried about childbearing. She thought, I never thought you were thinking about that. And it's always good to have like family interview or a couple interview, because they get to know about each other by having somebody else in a room. And they said, oh, I never thought you thought about that. And that kind of communication would be necessary during the pregnancy. So this was similar to what you just saw for the maternal mental health promotion program, reflecting one's thoughts, such as feeling pressured about having a child or plans that you have for your child. It's funny because when I asked, what do you want to do when you first saw the baby? And mother said, I want to hold, I want the baby to cling to my finger and feel the warmth, that kind of thing came out of moms to be. But what father says, I want to take him to camping and I want to go play in the playground. I'm like, that will be way ahead. But that's how men are sometimes. And they look forward to it, but they just don't know how fragile the baby is, and they're just so scared. So talking about like, how does it says policy, but what kind of rules would you have for raising a child? And it's like, you won't have time to talk about this after the baby's born. You're too busy. The babies are so demanding, and you will not have that much time. So I included that in the program. And also I wanted to include the depressive symptoms and postpartum depression. I want them to know correct information, not to scare them, but just to know that so they could go to a specialist once it happens. I don't want them to happen, but it could. So these are the contents. I did almost same thing, worksheet for both of them. See, the dads are here, and they can fill out at the same time. It's a group work. So while I was doing these researches, the movement of Japanese Obstetrician Society, I wanted to introduce. obstetricians were never interested in mental health much. They were always interested in something underneath here. And the mental health was taken care of with some other profession, they thought, but this is where they come before they give birth. So on 2014, they say consultation collaboration program to support people who are worried about pregnancy should be done in this obstetrician area. And the medical association believe that preventing postpartum depression and maternal-child relationship disorder is the most effective way to prevent infant abuse, and by obstetric and gynecologists considering mental health care. So finally, they realized that they are in a place to set the alarm or do the screening and see who needs more help and refer to somebody specialist. They don't have to do it, but they can refer to somebody who can do that for them. So, this is just the declining postpartum depression rate in Japan. I'm sorry, this is the report from the government, because they have the Healthy Parent and Child campaign in 2005. And this was 2005 data. 13.4% was the postpartum depression rate total Japan, and in 10 years later, it became 9%. So it declined, and it has effective. And the research that I have done and other research has done to prevent these kind of postpartum depression prevention measures. So those were implemented in the clinical field, and I think that helped this number, which I think I'm very happy about that. So they have issued the second stage of healthy parents and child, which is issued in 2015, will lead to 2024. I'm sorry, I didn't have time to translate in English, but this slide is actually same. It's to prevent, to support continuous care of mothers, but this slide is a little addition to what we had before. We were still experiencing total fertility rate is getting decline. And that is due to feeling of there's not enough support in a society to have a child, or it's not a support to have child while you're developing career. So this side is targeting to more of teenager or more of future moms to educate how to take care of their physically body in nutrition basis and mental phases, and also to appeal to the society that there should be a societal help to accelerate more child to be born, actually, to have a healthy environment for child's rearing. So that was additional to the new campaign of healthy parents and children. So this is my last slide. I wanted to know that I decided to kind of design my research, not always, but especially in this area, because I wanted to disseminate it all over Japan, to know what the policy is to develop by the Ministry of Health and Welfare. They wanted to decrease the amount of onset of postpartum depression by changing the environment, and they were looking for a procedure to do that. And if you have a good evidence of research, they will look for that. And also, if the research is designed to be adapted easily to what is going on in the routine, that will be pretty good. It will be maintained in the research, in the clinical setting. So I have found this RE-AIM. Have you ever heard of RE-AIM? It says for the research, it is said in the literature, the finding of research, actually put it into practice, it takes like 10 years or so to actually put it into practice, and we don't have to wait that long. If you reach, if it's adaptable, acceptable to setting, you could reach, the participation rate will go high because all the mothers have to take maternal classes. If I put that into maternal classes, it will be disseminated to all, it will reach all the participants. And effectiveness will broad impact and who benefits it. an adaptation, which setting can be delivered in the program. And I said, oh, this maternal class will be suitable for my program to be set it. And it's only 20 minutes more. It might seem long, but could be implemented pretty easily. So implementation, it doesn't cost that much because it's already set it. And so, and if they find it effective, it will be maintained. The maintenance can be done there. So I think what I did talk about today is how I met the theme, the topic of postpartum depression, and I wanted to help these moms and family. First, I was only focusing on moms, but fathers also are a very important player in this issue. So I've developed a program that will reach to both of them. And while I was doing it, I was watching what was going on in political will, and I kind of combined that together. So a lot of hospitals and clinics are now trying to reach to both of them with correct information, necessary information, and also seek out who needs more help, because our resources on our side is very limited. So we have to find out who needs more help. And that's what I wanted to talk about today. I think this is my last slide. And this is acknowledgement. Okay? Thank you. It was too long?
Wow, that was great timing. My name is this on?
I guess not.
Oh, just a second. Hello.
It's,
All right.
it's not on?
It's not working. No.
Oh, no.
Now it's working. All right, great.
Before I came to Alverno, I found out I was pregnant. And I had the baby within the semester and didn't even miss not one day of class. But I also feel that had possibly caused some of my depression afterwards because I was so focused with school. And now my son just turned 3 and I notice I'm way more depressed and I feel like a lot of the feelings. Is that possible to have postpartum so late because you're distracted?
Sounds like a good question.
Oh, yeah, okay, this is on, okay. Well, postpartum depression is a diagnosis thing that is, the onset is limited after 4 months to 1 month. And so you maybe have depression, but it won't be called postpartum depression. But it could happen, I mean, this could come back after a few, see, I met these moms after 3 years. So the baby was 3 years old. And their mental status, we don't call it postpartum depression anymore, but they were depressed because they have some overwhelming task with less help. And in your case, you were focusing on your schoolwork, and that must be very hard. So it could be, and you need to manage and organize and get more support and to feel better about, yeah. Yes, you were at the simulation center, right? Yes, I remember you. Did I answer your question? Yes?
was so late that like it slowly did, and I didn't know if it was school, but I have more depression when it comes to my children than anything else. So, and that's why I didn't know if maybe there was a relation to that, you know, and like I said, maybe I've been so focused with school for the last 3 years that it just finally hit me. So that's, I guess, where, like, I found this all very interesting. So, thank you.
Okay.
All right, who else? It's working. Okay, Valley and Kelly. Okay, all right, coming right over.
Yeah, I was just wondering if there's any screening or any thought of if any of these women have underlying depression before their pregnancies. Does that factor in at all? And,
Yes. That's one of the risk factor that is very big risk factor that they have a depression before the pregnancy. And the questionnaire I asked, I did the interview, but I also asked questionnaire, and that included postpartum depression inventory in Japanese version, which I developed. And within that, there is a criteria that have you ever experienced a postpartum depression before pregnancy? And so I do use that in the screening.
and do you know offhand what the depression rates are like in Japan other than postpartum depression?
Other than postpartum?
Yeah, just like depression.
Oh, in general?
Yes, is it common in Japan?
It is. Well, I won't say it's a global issue, and it's not really different. But 20%. But it varies by the ages. And recently, you have report that a lot of elderly people are getting depressed. We have longevity, very long lifespan, and people just get really depressed in their 70s, and also men in 40s. When we have that's the highest suicide rate in Japan. Is it here too? I don't know. And all of them. Oh, okay. Well, men in 40s have a very high suicide, and it is said that one of the reasons is the depression. So that's average 20%, but it varies by the age and the gender. I don't have an exact number. Okay. I'm sorry. Yes.
Thank you. I'll be over.
Is there a website we can follow you on to continue to watch your research?
What?
It's very interesting.
Well, I would like to tell you, but I'm still working on a journal. I mean, an article writing about this, and I don't have any like homepage that explains in English.
What a great idea.
Yeah, great idea. I'm going to try to do that, yes, if you're interested.
I'll come
yes.
back.
Thank you for your interest.
I was going to ask another question, but you made me think of another question. Are you going to, or have you looked at women in relation to depression and like guilt, the emotion of guilt, like if they are going to work or they're going to school or they're doing other things, and how that could impact, their depression or depressed mood?
I haven't done that yet. I'm very interested because a lot of women are now working. They used to quit their job when they have a child. They never quit when they're married. That's been taken care of. But when they have a first child, even that we have a very good law that you have a maternity leave, not paid sometimes, but your pension, your benefits are all paid by where you're hired, but you can get a year off and come back after the year. And sometimes 2 years, like Japan, IBM, they allow you 2 years of leave. And if you have a child between that period, you have like 4 years in a row. Big companies can do that. Well, anyway, during their leave, though, they feel like they're so happy with the child when they have to put it in the daycare and come back to work. I hear a lot of moms says they feel very guilty, and that the work should be really good to leave my precious child in the child care. And that kind of, I think it's same globally, but I have not done like research or anything like that. Okay. But we have more support, and even after you go back after a year of maternity, child-wearing leave, you can have a shorter time of like phase back period. You can have a shorter hour of working until the child reaches to elementary school. But that's only valid in big companies. Like in where I'm working in university, I don't think they allow you to do that.
Here's my original question, though. When you were getting people to be part of your sample, did you have any difficulty with them being fearful about if they tell you these things? You know, were there just women who said, no, I don't want to participate because, you know, they're worried? You know,
They were
just
interested.
culturally, would they be worried about
Actually-
saying anything that might make them be viewed in a negative way?
See, I did this recruitment of attachment style interview and all that in maternal class. So usually there's like 20 people, and I hand out the recruitment sheets, the research request, and I don't know the reason why they declined. Not all of them participated. And once they hand in, I contact them and do the interview. And so it's biased. They're willing to talk about it. And once they come, like I've met many fearful attachment style people, or I've only met two enmeshed people. So people who are fearful may be inclined to, come into the research. But while they were answering my questions, I have these set it up questions. I could feel that they were a little worried about like how much more I should talk about this. Is that your question? But I gave them I'm a clinical psychologist, so I gave them a safe statement. This will not go anywhere, and they felt safe to talk about it. And I think it was. But all the samples have bias, so I may have missed some of them who are really in need, but don't want to participate in the research. That's everywhere. So I think outreaching is important too. People who comes in and want to talk about is already in safe, area. But people who cannot come and talk about it is that we should outreach more. Yeah. But they were kind of interested in it because they thought it's like kind of like I told them you will know what kind of type your attachment style is. It's like, how do you say, like, I cannot find the word in English. They want to find out what type they are. It's kind of fun. Huh? They were curious. Curious or usually blood type AB is this type, blood type B. They like to know what type they are. So, and the feedback I gave it to them is in the wording in that they could accept. So for a mesh style, I think I touched on that. I said you're very social. You always want to be with people, but maybe you should, and I gave them advice. And if it's fearful, I said you're very cautious. You're always, you don't go, you have certain distance between people. But sometimes you need to get help because childbearing is really a tough job. So these wording they like. Oh, I'm very cautious, not fearful. They don't like fearful. And for angry dismissive, they'll say, you're very, I forgot the word in English, but secure, I just say secure. You're very secure attachment style.
Thank you.
Hi, I'm a psychiatric nurse practitioner, and in my outpatient clinical practice, one of the things that we kind of look for as far as postpartum depression is it could possibly indicate underlying bipolar disorder. I'm wondering if you've ever seen anything about that or noticed any correlation between the two.
Actually, I didn't go into the attachment style in detail because I won't have that much time. But along with these 4 insecure attachment style and secure, there's disorganized style. You will experience evenly of different attachment style. That's contradiction to it. That it's bipolar people are you could tell by you cannot profile into one style. And there's another category called disorganized attachment style. So that I will refer to, people who really knows about the symptoms and phenomenon. So yes, there is. Thank you for asking.
Hi, I have a question.
Where are you? Oh, okay.
Regarding social media, how would this affect a new parent, a new couple,
Yes.
or new parents, I guess what I'm trying to say? Would that increase their depression? I know like within like normalcy, there's increase in depression, but if they're already prone to it, what are your thoughts on that?
Well, that's a very good question. My first meeting with these moms, they were always on cell phone, social media, and also emails. They want, if the response does not come immediately, they're worried that they did something wrong, that I won't be her friend anymore, these things. So in terms of building a relationship, I think how you use it is important. And people who are just enmeshed or fearful, they're just online all the time to figure out how they're being taken with other people. But as for information basis, some couple have too much information through internet and also SNS. Sometimes these information are incorrect, so they accelerate their anxiety too much. So I tell them to go to a really correct one. If you go to clinic, ask for the correct information. But some SNS are really useful. They have, I don't know if it's SNS, but a kind of program that if you're in this month of gestation, this will happen. And husband, it's cute. Husband checks on that and say, oh, I have to do this to my wife, you know, she's in this situation, so I shouldn't, you know. And knowing that husband is really trying to get the information and trying to care for the wife, it makes the wife really happy. And these information could go timely through internet or SNS. And I hope it's correct when it's distributed. So it's either way, you know, it could be used in a good way if it's correct. And if your character is that you could seek a good information and take it, not take everything. They get overwhelmed with so many information. So sometimes I tell them, after they have a baby, just put the cell phone down and look at the baby. But usually, yeah, I don't know if it's here, but sometimes mother uses cell phone to babysit the baby. With the cartoon, the animation, manga is big in Japan. And I see that in trains and, ooh, don't do that. Because that will hurt baby's eyes. It is evidence that looking at screen in such an infant age, it will damage your eye, the momaku, right? Yes. So, am I answering your question?
Partly.
Yeah.
One part I was concerned about or thought about was, when you compare yourself with other parents and like, oh, they look perfect. And like you said, you know, what am I doing wrong? Or, you know, but just because they get that instant feedback. I guess you did answer. Yeah, you did, I guess.
Yes.
Sorry.
No, it really happens. And if you're in Tokyo, you will see moms pretty nail and high heel and a wheelchair, and they think it should be that way instead of, you know, mess. But child wearing is really a lot of job, and you don't really have to do everything perfect, but they're under pressure in the city side. But I don't know about rural side. Japan is small, but it's diverse too in different areas. And I see a lot of women in Tokyo area that they feel that they have to really be nice and be calm and be confident. And if you're not, you don't go outside to meet with these moms. That's sad.
Other questions? Oh, great. Okay.
Hi.
Hello?
Okay, so I know you said that the mothers get the screenings and they have to do the questionnaires, and they have different. My question is, their findings, are they different than when you do the couple one? And because you said there's the secure attachment or insecure attachment, are the father's findings, or when you do it as a couple screening, are the results the same?
Oh, okay. I didn't do attachment style interview to the couple.
Okay.
So that study is totally different one. Okay. So I wish I could do men, which they don't say yes. I mean, I recruit, but they never
Right.
get it online. So,
Yeah.
but there are a lot of literature that attachment style, this type of attachment style, usually marry this attachment, and they do pretty well. There's a literature that the couple who has this certain style and certain style that's really form good team in doing child rearing. In their in abusive relationship, also if you screen out an attachment style interview, there's a certain
Indication.
indication. Yeah, but I haven't done it.
Okay.
Yes, that's a good point.
Thank you.
Thank you.
Anyone else on this side of the room? Okay, I'm going around. So say something, Mari.
A lot of exercise for Judine. Thank you for good questions. I'm glad I hope I made myself interesting. I talk too fast.
That's Tanya.
So you said the interview process can take up to an hour sometimes. Is there any way to make like almost an abbreviated version of it so it can be more utilized by like nurses and stuff in hospitals, like pre-clinic and pre-checkups and stuff like that?
I get that question a lot. Well, this was research, so I could sit down and do an hour interview. In the questionnaire that I did together with the attachment style interview, I said it before, it's PDPI, Postpartum Depression Inventory. You should look at that. It's written by Cheryl Beck, Postpartum Depression, Postpartum, PDPI is the name of the scale. But it has a questionnaire asking this very confining, there's partner saying, can you confine to your partner? Can you look for support? So this question, one part of the question in this screening is talking about attachment kind of style. Only the first phase. Remember I said first phase, you ask about 3 people, your husband, partner, and 2 other people that you pick. And you ask about how much can you confine in this person? How much emotional support are you getting from this person? And do you feel attachment to this person? That's kind of semi-structured questions in first phase. And that measures your level of attachment. Then in phase 2, you ask all these 7 criteria of attitude to put it into the styles, different styles. But the first phase will measure the level of attachment, and that could be done in that screening sheet. It will not take much time. So I tell nurses who are very busy and don't have time to sit 1 hour, and actually if you use that screen and found that this person needs help, then maybe you can sit down and do the depth. So I think you will be interested in that screening scale.
Other questions? All right. Well, I think it's amazing that one person's program of research has influenced policy. Isn't that amazing? And this is what we're inviting all of you to think about, how you can use what you're passionate about, because you can hear Mari's passion for this, but also use what you are really interested in to improve the world around us. And too often, most often, the best way to do that is through policy. So those of you who are with Rebecca Sabansky this evening and talking about that, this is a great opportunity for you to think about it, but for all of us, because there's lots of ways to influence policy, especially letting our Congress people know how we are interested in something they might be doing or we think they should be doing, either one, okay? So we have a small gift for you, as always. So thank you so much. For being a part of us this afternoon and evening. And we invite you all to take your various items, recycle anything recyclable, throw the rest in the garbage, and then go to class or whatever. But let's end by thanking Mary Ikeda for presenting.
Thank you. Thank you so much for coming.